Hello, everybody. My name is Uwe Platzbecker from the University Hospital Leipzig in Germany. It's a great pleasure to be here on this channel and actually discuss a very, I would say, complex question with regards to treatment decisions for so-called elderly AML patients. First of all, I would say that the terminology of elderly patient, also with regards to treatment decisions of either intensive or non-intensive therapy, is a moving target at the moment. We also have to stick in most of our countries to the label of a certain treatment, to the registration. In most of our countries, I think at the moment, the combination of azacitidine and venetoclax, or let's say HMA-based treatment plus venetoclax, is the backbone for so-called elderly AML patients. In the clinical practice, many of us use the terminology elderly for patients who are not eligible for allogeneic stem cell transplantation, because the patients, let's say, younger than elderly or not fulfilling the criteria of elderly are the ones we conventionally treat with intensive chemotherapy plus minus agents like midostaurin or gemtuzumab. And then in case of complete remission or chemosensitive disease, these patients are undergoing allogeneic stem cell transplantation. In all other patients, AZA-VEN or HMA-based treatment plus venetoclax is currently the standard of care. The registration trial for AZA-VEN actually had certain age thresholds, so patients above the age of 75 could be included, but also patients with comorbidities less than 75 years of age could be included. So therefore, the age range was quite wide, with also starting with patients younger than 30 years being included due to comorbidities. So therefore, I think as a rule of thumb, at least in our department here, we consider patients below the age of 70 years always first line for a treatment with intensive chemotherapy, because those are the ones where allogeneic stem cell transplantation should be considered also as a consolidation treatment. Patients beyond the age of 70 years are very infrequently considered because many of them can be called elderly because they have comorbidities, they are fragile, they have an ECOG of above 1. So basically, they would not tolerate intensive therapy and therefore should be followed with an HMA-VEN-based treatment. But I think there is a huge gray zone, and also patients can be frail and can be fragile at the very beginning of their AML diagnosis as a result of the AML itself, and which then may evolve and may get better due to treatment decisions. So I think, therefore, also clinical trials are very important and are on the way to compare both strategies exactly for these kind of patients. At the moment, my recommendation is to stick to the inclusion-exclusion criteria of the VIALE-A trial, which basically led to the registration of HMA plus venetoclax in these elderly patients, but still also consider clinical trials and also novel developments in the field.